A patient who would benefit from lumbar stabilization training would likely present with aberrant movements, which can be identified as a Gower sign, where they bend down and they have to lock themselves up, reverse lumbopelvic rhythm at the pelvis, an instability catch, they bend over, and then they catch, and then kind of move back to their position, or they have pain with movements, or it's identified as a painful arc. The patient would also have a positive prone instability test. So I have my patient lie down, gripping the sides, and then extend the glutes, good, and come down if that's painful. And then I apply a PA mode. My patient does that and comes back up, good, and their alleviation of their symptoms, then it's considered a positive. Have them come up. If my patient is less than 40 years of age, and then also if my patient lies down, you do a positive straight leg raise, lie down. And if on both legs or one leg, you can get beyond 90 or above 91 degrees, then it's considered a positive. A patient who would benefit from lumbar spinal manipulation would have less than a 16-day onset or an acute onset. They would have an FABQ of less than 19, which would be given to them in the clinic as an outcome measure. They would have no symptoms distal to the knee as measured by measuring the extensibilities of the tissues, as well as looking at neurological signs, other impairments upon palpation or whatnot at the knee. They would have hypomobility in the lumbar segment, so just as I did PA mobs in the previous video, you would be doing that, looking for hypomobile segments in the lumbar spine. Then the last thing would be a hip internal rotation of, on one side that would be less than 35 degrees, which would be measured using my goniometer. Line this up, the movement arm, have them move without compensation. And then if that is less than 35 degrees, then that would be considered a positive as well. And you're looking for 4 out of the 5 of those. In order to find meniscal pathology in my patient, what I would do is flex the knee to 90 degrees, and I'm palpating on the joint line to see if I can identify my patient's pain. Sensitivity and specificity for this test are right around 0.2 to 0.99, so they range or vary, all based on the palpator scales. A test that I would use to look for an ACL incompetency in my patient is I would use an anterior joint test. So what I'm going to do is block my patient's foot, and what you're going to do is you're going to pull the tibia on the femur towards you in an anterior pattern, taking both hands, firmly placing your hands, and you should feel a hard block. If you do not feel this hard block, then an ACL tear is likely. The slump test is a neurodynamic test, typically of the lower extremity, but it can also be used down the back. What you're going to do is you'll have your patient put their hands interlocked behind their neck. What you'll do is have them flex forward at the trunk in a slumped position or a slumped position. You'll extend this leg, and as you apply compression, and you dorsiflex the foot, and this reproduces their pain, this is a positive test. And then if you alleviate that by letting go or bending the knee and the symptoms go away, that would be also considered a positive. However, this has to be their pain. Some people have asymptomatic findings during this. An older patient coming into your clinic has a potential of having osteoarthritis. They're going to be complaining of hip pain. They've likely seen their primary care physician, received an image potentially, and that's one thing to ask them, is look into their history and kind of see what's going on. You would measure their hip internal rotation, as I measured earlier in that earlier part of the video. Then you're looking for a hip internal rotation less than 15 degrees. Then you're going to measure hip flexion, which I'll do right now with the goniometer. Placing my movement arm and have my patient flex up and down. Good. If my patient has less than 115 degrees of motion in hip flexion and also is in pain, they're likely to have osteoarthritis. However, if they have greater than 15 degrees in their hip internal rotation, but they're over the age of 50, they have painful hip internal rotation, and then they have morning stiffness that lasts about 60 minutes or less, but as the day progresses it gets better, they're likely to have osteoarthritis. A useful test in the clinic is the FAIR test. Once you palpate your patient, if you're suspecting some kind of radicular symptoms from the sciatic nerve or somewhere in the gluteus region, one thing to do is identify the piriformis. So my patient has a tender piriformis muscle. You would find that upon your palpation exam. One way to further look into those symptoms is applying the FAIR test, which is a flexion, adduction, and internal rotation test. So with your patient in the sideline, the symptomatic leg on top, you're going to flex them, adduct, and internally rotate, looking for the provocation of those symptoms as you stretch out that piriformis. This test is a highly sensitive as well as specific test, looking for piriformis symptoms or positive. Another test when you're looking for sensitive tests, especially when looking at the hip, is the Faber test, or the flexion, abduction, and external rotation test. What you're going to be doing is you're looking for suspected hip pathology, and if this provokes your patient's pain, or it provokes a very uncomfortable pain that's different than normal, then you're likely to have found a positive finding. So what you'll do is you'll flex the patient, you'll apply external rotation and abduction, and you're applying overpressure while stabilizing on the opposite hip. If this reproduces the patient's symptoms, then it's likely to be a positive. Differentiating between an L5 and S1 radiculopathy in a patient is likely to happen in your clinic. One of the useful things that you can do is you can look for whether it's a diffuse or an isolated problem. If it's a diffuse problem, you're probably thinking more radiculopathy. If your foot everters, your foot inverters, as well as your ankle dorsiflexors, hip abductors, and hip extensors are all weak, you're likely looking at an L5 or an S1 radiculopathy, which would be found during your fundamental exam, looking at reflexes, especially the S1 reflex, as well as your gross and isolated manual muscle testing. If your patient comes in and they kind of have a wonky gait, or something doesn't quite look right and it looks like there's a global issue going on, it's likely to be more the radiculopathy. An isolated weakness would be if your patient would flip over and you start to isolate out the glutes and the hamstrings. So, isolating out the glutes, you would flex the knee, taking the hamstrings out of the equation. You would have the patient lift off into hip extension, hold here. You would apply your manual muscle testing, holding for 5 seconds. And if the patient is strong, I would not suspect anything that would be more of a diffuse problem, especially if you're looking at more of the hamstrings or the glutes in isolation. Now, if her glutes are strong but her hamstrings are weak, or vice versa, then you're likely looking at an isolated problem. Versus if I begin testing multiple things, let's say I test the glutes, I test the hamstrings, I test the plantar flexors, I test the everters, the inverters, and we're looking at a global weakness, then it's more likely to be the radiculopathy.